Ovarian Adnexal Reporting and Data System, shortly known as O-RADS. This is just at a lighter note. In the earlier days, the adnexal masses used to be vaguely described. Our ultrasound reports would contain a report which said the lesion was simple or complex. But this didn't really help the surgeons. They weren't able to determine the malignant potential of the lesions, and many lesions went under the knife because of this reason and turned out to be benign. So, could we do it better? Yes, we could if we followed a proper morphological categorization system. There were many systems put forth, like the consensus statement by the Society of Radiologists, the O-RADS, the Kentucky Morphological Index, and the famous IOTA, which was the International Ovarian Tumor Analysis. It was very widely accepted. It had a mathematical calculation system or a model, which was the Adnex model, and after that came the O-RADS, which we are currently discussing. This primarily my presentation has been made based on these articles. The presentation will cover the following headings. So largely we can categorize the adnexal lesions into benign ovarian, benign non-ovarian, primary malignant ovarian, secondary malignant ovarian lesions. So the benign ovarian lesions are like polycystic ovaries, functional cyst, endometrioma, serous cystadenoma, mucinous cystadenoma, mature teratoma, fibroma, thecoma. The benign non-ovarian lesions are paratubal cysts, hydrosalpinx, tubo-ovarian abscess, and peritoneal pseudocyst. The various primary malignant ovarian tumors are epithelial carcinomas like serous, mucinous, endometrioid, and clear cell carcinoma, the germ cell tumors like malignant teratoma and dysgerminoma, the sex cord tumor like granulosa cell tumor, and there could be secondary malignant ovarian lesions that can be from primaries like breast and gastrointestinal carcinomas, where the secondaries are known as the Krukenberg tumor. So basically, O-RADS, what it does is, it provides us with an ultrasound risk stratification and management system for the evaluation of ovarian and other adnexal masses. It also provides us a recommendation to guide the management in these patients. And the patient selection criteria is, these are average risk patients without any acute symptoms. So what finally we get is, we get consistent interpretation across all the radiological reports. It decreases ambiguity between the ultrasound reports. There is a higher probability of accuracy in assigning risk of malignancy. It helps us provide a management recommendation for each category. It helps in guidance in the management of average risk patients who do not have acute symptoms. However, the terms and descriptors that are used in O-RADS are the ones which have been used in IOTA, that is the International Ovarian Tumor Analysis Group. So largely like the BI-RADS, which is a famously accepted category, O-RADS also has 0 to 5 categories, which is incomplete evaluation, physiological category, the almost certainly benign category, which has just about 1% risk of malignancy, lesions with low risk of malignancy, that is about 1 to 10% risk, lesions with intermediate risk of malignancy, that is 10 to 50% risk, and lesions with high risk of malignancy, which is greater than 50% risk. So if we see an adnexal structure, we should be able to divide it either into a physiological or a lesion. It should be divided into one of these. If it is physiological, it will be either a follicular cyst or a corpus luteal cyst. However, a lesion needs further characterization. So the common lexicon that is used is there are many categories in which we divide it. You can, like we said before, it can be divided into physiological, which is follicle or a corpus luteal cyst. It can be a lesion, unilocular cyst with or without solid component, multilocular cyst with or without solid component, or a solid lesion. Size has to be measured. Solid lesions need to be described with their external contour and internal content. The cystic lesions have to be described with their inner margins, internal component. In the internal component, the cystic and the solid component has to be described. The cystic component will have there are certain very classical descriptors like for the dermoid or the hemorrhagic cyst. Otherwise, we have to describe the fluid and the septations. We have to also give a category for the vascularity, and if there is an extra-ovarian finding, that has to be described like the classical descriptions for the para-ovarian cyst, fallopian tube, peritoneal inclusion cyst, descriptors used for fluid, peritoneal thickening or nodules, and adenopathy. Now coming to the major criteria, which is out of which physiological category. We describe a follicle classically as a simple unilocular anechoic cyst which is less than or equal to 3 cm in its maximum dimension, and this is in the premenopausal group. Next comes the corpus luteum. It is a thick walled cyst, again less than or equal to 3 cm, that may have a crenulated inner margin, can contain internal echoes, and often has an intensely peripheral color Doppler flow. When we categorize the lesions based on the IOTA classification, we have a unilocular cyst with no solid component, unilocular cyst with solid component, multilocular cyst with no solid component, multilocular cyst with solid component, and a solid lesion, by which we mean that greater than 80% of the lesion is solid. So now when we come to describe the unilocular cystic lesion with no solid component, we have various descriptors in that itself. It can be a simple cyst, that is unilocular cyst with no solid component, septations or contents, it having an incomplete septum, it having an irregular inner wall. When we mean irregular inner wall, we mean that the nodularity should be less than 3 mm. It can have internal echoes. It can have fine echogenic strands, that is reticulations. It can have large dominant echogenic areas, which is the echogenic component. When we describe a unilocular cystic lesion with solid component, we mean that this solid area has to be greater than 3 mm. If it is less than 3 mm, we describe it as an irregular inner wall. If it is more than 3 mm, we describe it as solid component. Next, we can have a lesion, cystic lesion with multiple septations. Then we describe it as a multilocular cystic lesion, and if with no solid components in this particular scenario. Next is again multilocular cystic lesion with solid component, again meaning it should be greater than 3 mm. And a solid lesion, as told before, has to be a lesion which has a solid component which is larger than 80% of the lesion. The size that has to be measured in the maximal dimension in two distinct planes. Volume measurement is an optional category. Maximum dimension of the solid component should also be measured if this lesion contains a solid component. Lesions which are large, that is about greater than 10 centimeters, and lesions which have a larger solid component, that is greater than 0.7 millimeters, tend to have a higher risk of malignancy. A solid or a solid appearing lesion, for that we need to describe it under two different areas, that is the external contour has to be described and the internal content. External contour can be smooth or lobulated or irregular. If there is irregular margins, it has a higher risk of malignancy. The internal part of the solid lesion should be described in comparison with the ovarian stroma. whether it is hyperechoic, isoechoic or hypoechoic as compared to the ovarian stroma, whether there is any presence of calcification or posterior acoustic shadowing. The cystic lesions have to be described with respect to the inner wall, internal content, and internal content when there is a solid area separately should be described. So the inner wall can be smooth, irregular or have a wall calcification. Irregular, we already told the irregularity should be less than 3 millimeters. Internal content, it can be hyperechoic or it can have this classical description like ground glass description is described for endometrioma. Retracted clot, reticulations, fluid levels are described for a hemorrhagic cyst. Hyperechoic spherical floating structures or hyperechoic line and dot fat fluid level is described for the dermoid. And otherwise we should be describing the septations which can be incomplete, which is more classical of tubular pathology. Thin when it is less than 3 millimeters and thick septations when it is more than 3 millimeters. And incomplete and thin septation both are more in favor of a low risk. Internal content or solid areas. The solid areas, when it is greater than 3 millimeters small ones, they are called as papillary projections. So the size and number should be mentioned. Greater than 4 papillary projection points to a higher risk of malignancy. We should describe if this solid component has a smooth or an irregular contour. Next comes descriptors for the vascularity. Vascularity can be circumferential or internal, and there is a color score which is attributed to the vascularity. Color score 1 means no vascularity, color score 2 means mild vascularity, color score 3 means moderate vascularity, and color score 4 means there is significant vascularity. Next comes the extra-ovarian findings. So we have to describe it classically. If there is a para-ovarian cyst, the descriptors used for the fallopian tube is the presence of an incomplete septation or a tubular cystic structure. The peritoneal inclusion cyst is described as a cystic structure with clear contents which conforms to the walls of the adjacent structures and does not cause any mass effect. The descriptors that are used for free fluid is if there is free fluid in the cul-de-sac, we have to describe it whether it is clear or this fluid has any contents. However, if the fluid extends above the fundus of an anteverted uterus or lies between the uterus and the urinary bladder in the retroverted uterus, then we term it as there being the presence of ascites. We also have to make a note of if there is any peritoneal thickening, and if it is present, whether it is focal or diffuse, if there is any presence of peritoneal nodules or serosal deposits, and also of the presence of any adenopathy. This is just to give an example of the descriptors. In this multilocular lesion, we are describing the maximal diameter of the lesion. We are also measuring the maximal diameter of the solid component, and we are roughly telling the number of locules present. If there's papillary projections, we mention the size of the papillary projections and the number. And if whether there is any calcification or is there any acoustic shadowing posterior to it. We also have to comment on the presence of any extra-ovarian findings like ascites. This is just to describe it in short. So now coming to examples. This is a lesion. When we classically describe this, these are just like a quizzing thing I have kept it. So this is just a multiple choice across it. So when you quiz yourself, what are the descriptors that you would be using? What we should be using is, it is a physiological entity and it's a corpus luteal cyst. Here make a note of the measurement also. So what will be the descriptors that you will be using? It is a lesion because it is greater than 3 centimeters. It is a simple cyst, unilocular cyst which has no solid components. Coming to this lesion, we will describe it as a lesion with what kind of contents. It has scattered low level echoes, and it also has a small papillary projection. In this lesion, the descriptors out of the ones which are given, the ones which we would be using is, it is a solid lesion with irregular outer contour. Again, the same lesion, if we have to grade the color scoring for this lesion, which grade would we put it in? It is color score 2, which is minimal vascularity. In this lesion, what would be the description that we would be using? It is a solid lesion with irregular outer contour, internal vascularity, which if we put the color scoring, it would be color score 3, which is moderate vascularity. So now when we come to the common lesions and the classical descriptors we use for it, we know the first lesion is a hemorrhagic cyst, and the classical description used is a reticular pattern. The next is an endometrioma, and the classical description is ground glass contents. These are the descriptors we should be using. The next is again a hemorrhagic cyst, and the descriptor used is a retracted clot. This is not a common appearance that we see for a dermoid. However, this is described as floating echogenic spherical structures. So now when we come to categorize them, O-RADS 2 is the almost certainly benign category in which the likelihood of malignancy is less than 1%. So in that we have a simple cyst which is greater than 3 centimeters but less than 10 centimeters in premenopausal, and anything less than 10 centimeter in a postmenopausal women. There can also be non-simple cysts which are again unilocular with smooth internal margin and less than 10 centimeter. However, it can have contents and septations, thin septations, incomplete septum especially. Next, we can have a O-RADS 3, that is the low risk, which is 1 to 10% likelihood of malignancy. In this, you can have the unilocular cyst, which is more than 10 centimeters, or the classical descriptors like the hemorrhagic cyst, dermoid cyst, endometrioma, but all of them about 10 centimeters, they fall into O-RADS 3. Then you can have the unilocular cyst with irregular inner margin of any size falls into the O-RADS 3 category. This irregular margin means again less than 3 millimeter in size. Multilocular cyst which has less than 10 centimeter size and color scoring of 1 to 3, that is no vascularity to moderate vascularity, and solid appearing lesion with no flow within. Now coming to O-RADS 4, that is intermediate risk, that is 10 to 50% likelihood of malignancy. In this we can have a multilocular cyst which is greater than 10 centimeter and has a color scoring of 1 to 3, or a multilocular cyst which can have a color of any size and has a color score of 4, of multilocular cyst of any size having color score of 4, or irregular inner wall or irregular septations, or having solid components. All these fall under intermediate risk. Similarly, a unilocular cyst which has solid components and is of any size or any color scoring, and at the same time another unilocular cyst which has 1 to 3 papillary projections, again of any size or any color scoring, they all fall into intermediate risk. Solid appearing lesion, if it had color score of 0 to 1, that is practically no vascularity, was in category 3. When it is having mild to moderate vascularity, it falls into category 4, and this can also be of any size. Next comes O-RADS 5, which is high risk, that is greater than 50% likelihood of malignancy. In this, a unilocular cyst which has more than 4 papillary projections, it is considered highly suspicious, or it can be of any size or any color score. Even then it will stay into O-RADS 5. Multilocular cyst which has solid component and color scoring of 3 to 4, any size falls into O-RADS 5. solid lesion with color scoring 4 or having irregular outer contour, it all falls into O-RADS 5. And in addition, if there is any extra ovarian findings such as ascites or peritoneal nodules, that again conforms to O-RADS 5. Now this is a description that I have taken from the journals that I had quoted earlier, but these descriptions are pretty crowded. They have the lexicon descriptors, and also they are having the management that we would suggest in a premenopausal and in a postmenopausal women. We have already gone through the descriptors, so I wouldn't be repeating it. So I have I've made it really short in this tabular column, and I'm just talking about the management here. O-RADS 2 is a simple cyst which is less than 10 centimeter, a non-simple cyst like a classical hemorrhagic or endometrioma or dermoid which is less than 10 centimeters. For all of them, in a premenopausal women, we would do a follow-up at 8 to 12 weeks, and in a postmenopausal woman, we would do a follow-up at 1 year if it was less than 3 centimeters, and we would proceed for an MRI if it was anywhere between 3 to 10 centimeters. In O-RADS 3, that is the O-RADS 2 cysts, that all the cysts that we have described in O-RADS 2, which were greater than 10 centimeters, a unilocular cyst of any size having irregular wall, a multilocular cyst which was less than 10 centimeters, having a smooth inner wall, and color scoring of 1 to 3. All of these fall under O-RADS 3 and would be needing an additional MRI or would have to meet a gynecologist for further evaluation, for further workup. O-RADS 4, unilocular cyst with a solid component, multilocular cyst with a smooth inner wall greater than 10 centimeters in size, color scoring of 1 to 3, or multilocular cyst of any size with smooth inner wall having color scoring of 4, or of any size having an irregular inner wall, or multilocular cyst with an irregular septation or having solid components, and smooth solid lesions, all would be O-RADS 4, and they will need MRI and a gynec onco consultation. O-RADS 5 was a lesion which was a unilocular cyst with greater than 4 papillary projections of any size, multilocular cyst with solid component of any size, solid irregular lesion of any size or of color scoring 4, or if there was any extra ovarian findings such as ascites in peritoneal nodules, all these would put it into O-RADS 5, and these patients needed a gynec onco consultation. So what we basically understand is O-RADS helps us in the standardized terminology that is to be used for evaluation of an ovarian and an adnexal mass. It helps us in risk stratification. It helps us provide a consistent and accurate interpretation of the malignancy risk, and this is uniform across all the radiologists. It determines optimal patient management strategies as per the protocols that they have suggested, and it helps maximize the clinical impact of ovarian and adnexal ultrasound. A uniform reporting system always helps us understand the report better, helps us utilize the report to its maximal extent, and the acceptance for these reports is better. And because there is a management strategy that is suggested, it helps us in further suggesting a management protocol for these patients. Thank you.